Afternoon. Good afternoon, everyone. Thank you for coming, especially for this topic today. I realize that it is not necessarily, a fun topic that you may have had at the Echoes before. So today we are going to talk about how the different types of client death in particular can impact mental health clinicians and other providers. So there's a lot of content related to this that you will see on the slides. I'm going to move through the slides very quickly and just highlight a few things here and there. But you'll be able to be sent the slide deck afterwards, which also has my contact information. So I am the director of the Criminal Justice Coordinating Center of Excellence. It is my full-time work. Beyond that, I also work with Light After Loss, which is a nonprofit organization in Stark County, Ohio, that exclusively provides peer support and other resources to individuals who survived the suicide loss of someone in their life, whether it was a family member, a colleague, a peer, a friend. It doesn't matter. We work with all types of suicide loss survivors. So to tell you just very quickly a little bit about me today, my background is in psychology and counseling, and my PhD is in counselor education and supervision. Related to this was actually my dissertation, which looked at the experience of mental health clinical supervisors after a client suicide. My personal and professional experiences have included natural death of clients, as well as multiple suicides, including a minor, which, time permitting, I'll talk a little bit about today. So this is a topic that's very important to me, and something that I hope, while it isn't fun to think about, right, isn't maybe something we want to dive into, my hope is that today will at least make thinking about it a little bit, just a bit more accessible, and give you some things to consider taking back to your staff or your agency or organization. So why should we be talking about client death? So one of the most important things to remember is that any type of death in someone's life can trigger some kind of grief response, loss response, completely normal. It's also very individualized. The other reason I think it's important to talk about this is also to emphasize one of my mantras, which is that grieving the loss or the death of a client does not make anyone less of a clinician or a mental health provider, nor does it indicate a lack of competency or ability to work in our field. And also because the reality is that loss happens, and loss happens in our personal life and our professional life. And while we may have slightly different responses to it, there can be some overlap. There's also indications for supervisors, agency leadership that should also be aware of this and be thinking about it. So one of the things to keep in mind is there's also an environmental influence, right? The types of clients you work with could be part of the types of loss and death you're going to end up facing. So something to consider is that where you work and the types of clients you work with may be an indicator of what types of death and loss a mental health clinician is going to experience. For example, working exclusively in addictions and on the substance use side of things, you may run into more overdoses. Working with the elderly, you may run into more natural deaths, from old age. Working with the severely mentally ill, you may run into sometimes more health-related deaths. Some violence-related deaths might be more likely working with the severely and persistently mentally ill due to their behaviors and how other people interact with them. Working at a crisis center, which is where I started my career, you're going to be more likely to run into dealing with a client suicide. And then urban, suburban, and country could have influences on different types of accidents that happen. Obviously, homicide rates are going to be different in those different areas. And then also thinking about working with minors all the time, all those things kind of lead into what type of death you may experience. So overall, there's several typical responses to the death of a client. I've listed them here. But primarily it's a lot of kind of internal feelings, guilt, responsibility, doubting ourselves, wondering if we should stay in the field, should we continue to do this work is very common. There's also sometimes a tendency to seek out consultation supervision more, right, which isn't necessarily a negative thing. But there can also be the other side of this where sometimes clinicians may avoid similar clients or similar clinical situations after going through a loss. Again, these are kind of your typical responses, but what we're going to go into now are some very specific types of death. So I'm going to go through each of these and highlight very briefly some of the added layers, right, that can come with these specific types of deaths. So we're going to talk about natural/accidental, Homicide, which can also include homicide related to domestic violence, gang-related, police custody, and also, unfortunately, random violence out in the community. Overdose, when it's the death of a child or minor. I left COVID in here just for one very particular reason, and then also suicide. So the reason we want to talk about these specifically, right, and kind of break down, talking about what clinicians and other support staff. So when we're going to talk about clinicians mostly, but keep in mind that your organization is a community. It's a system, right? It has life in it. So there's other types of providers, including your front desk staff, volunteer coordinators, different other positions that are also potentially going to be impacted because they also had a relationship with this person that's now gone. But we talk about these specific types of death because they can carry additional layers, whether it's due to the context or the circumstances of the loss. There may be additional indicators for clinical implications. There may be additional things that the clinician or those involved with their care may have to do in connection to the death, which might be unusual or kind of new for the clinician or the mental health provider to go through. These types of death are complex. They have moral complexity. They have literal complexity. They have response complexity. So because of that complexity, we know from working in mental health that, you can't always have a hard dividing line between professional and personal and what's going on. So the more complex the loss is and the implications of the loss become, the more complex the response is and the more possibility you'll see it in multiple areas. And like I've mentioned before, there's also with these more indicators of need for potential supervision intervention, additional support. And I also postulate that having the appropriate support and us better understanding how clinicians are going through these losses is also a workforce related issue, which I'll talk about a little bit later. So when we're talking about a natural or accidental death, I list this one first because these are kind of the deaths that most of us have gone through at some point in our life. Someone has, passed away from a long-term illness. Someone has passed away from age. These are typically the type of loss that we have some level of experience with personally. And also these are in general kind of more accepted losses. Natural loss is natural. It's kind of supposed to happen. Accidental loss, though, may not feel like it's supposed to happen. There isn't necessarily something to point at or an entity to point at as to the cause, right, of the accident. Now, of course, given the circumstances of the accident, that can change a bit. But this is kind of out of all of them, kind of the most typical responses, right? There may be very minimal need for the agency or supervisors to do much more other than their typical, post-client death, navigation of records and things like that. It can feel more accepted or anticipated. Of course, there's also, potential feelings of lack of power or lack of empowerment in what's going on. And it also may be, these types of losses may feel a little bit easier to separate from whatever care was being provided to the individual. Now, a little bit differently, when we look at, death by homicide, this has some significant added layers, right? This is the added layer. It's a crime. It was someone else who did it. And there is the potential for the mental health provider to have to be part of the process as this moves through the criminal justice system, potentially during an investigation, potentially even during trial. So that in and of itself is a huge added layer for mental health clinicians who are also, in the process of grieving the loss of someone that they were working with. Depending on the circumstances, this can also trigger some other very strong feelings. There can be feelings of guilt, responsibility, in particular if connected to domestic violence, but it can also sometimes bring on anger towards the client for maybe not leaving a situation that we as the clinicians feel they should have. Or if nothing comes of the investigation, could also be anger and disillusionment at the criminal justice system, right? Because this is now left unsolved. So there can be a lot of layers here that then, of course, are playing out in several different areas. With domestic violence, I mentioned those significant layers of guilt, responsibility, and anger. gang related, it can depend on if the client was a member of the gang. There can be some anger at the client for not leaving, not making steps to be safer, or to separate themselves, from the situation. With police custody, you have all of these additional layers, and you potentially also have quite a bit of media attention. There may be additional issues related to trust, racial and cultural issues. There's also then, of course, how the agency or organization and that provider have interacted with the police in the past and what that continuing relationship looks like in the wake of this. And then honestly, when it's random violence, it's a shooting, it's a burglary gone wrong, different things like that, that can bring up a lot of those existential questions and disillusionment just about being alive in the world, and some of those real big questions when, again, we've now lost somebody, we don't necessarily have a cause, and in a lot of situations don't really have anyone to point to. And that can feel very incomplete for a lot of folks. So when it's the death of a child or minor, again, lots of feelings of guilt and responsibility. There can also be a lot of feelings of perceived blame from other staff or even other clinicians surrounding the death. There's typically a lot of concern for the family, especially if there are other children directly impacted by the loss. There can be a lot of assumptions of being blamed by the family. There's also situations where the clinician may just be blamed by the family. And so this one can carry, a lot of weight. And now we start getting into that, also seeing more of that self-doubt about competencies, ability to work with others and other types of clients like this. One of the suicide losses that I went through was a 16-year-old. So they were a minor, and I'd been working with the family. And honestly, this was very similar to my response. I was very worried about being blamed by the family. I was very worried about the family, but also because of what was and wasn't put in place, wasn't able to have any further contact with the family. So that was also very difficult. So I left COVID on here. I added this into the presentation a few years ago because of some of the political ramifications, but this is another one where you start seeing other people blaming the individual who died for their death, kind of blaming the client for their own death when they've had complications from a potential COVID diagnosis. So this starts to open the gate also to other types of death, where we start seeing it's not just us navigating our own reaction to it, but kind of having to navigate how other people are reacting to it, and typically in maybe a client blaming or system blaming way. So as we talk about when someone dies from an overdose, again, you're seeing some of the same things over and over again, but this is another one where the mental health provider or clinician may feel significant anger towards their client or towards their client's circumstances. The additional stigmas of overdose and substance use may also have to be navigated in connection to the death. That could come up from other clinicians, talking around the agency. That could also come from potentially how the death is reported in the media and seeing the media and the community response to the death. So this can also have quite a few layers to it. So suicide has a lot of similar layers as overdose does, but in particular are also the personal and professional stigmas about suicide can conflict. As a mental health clinician, we may be voicing that we believe that all suicides are preventable. And at the same time, as a person, we can look at the data to know that that hasn't rung true for many, 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 many years. Additionally, there was a study done in Ohio in 2016 to look at what the impact was on mental health clinicians, social workers, psychiatrists, psychologists, counselors that experienced the death of a client by suicide. And you can see, some of these are kind of expected responses to a suicide loss. However, I want you to pay attention to the 13% of those individuals surveyed took time off work, meaning between 1 to 4 days. And a third of them considered completely or partially changing their career. What I forgot to put on here was that then a third of that group left the field completely. So there is a component where this starts to be a workforce issue when you start looking at your agencies and organizations and, your policies around client death, the support resources that are available, and how well supervisors understand this in order to help support and guide a clinician or any other provider or other staff member through this experience. So I didn't want to leave you with nothing, right, to just have this information to stew on. So I wanted to give you some things to be thinking about with what do you do with this information? So one of the first things is if you know that a coworker or colleague is struggling with a client loss, one of the things you can always do is, first off, making sure that you're in a good place to be helpful, right? If you're in a good place with the situation to provide support yourself, or there are things you need to do for you first before you can be in that space. The other thing to be very mindful of is, again, remembering that responses to loss, while there are very typical ones, it also is very individualized. And what people find helpful and supportive after a loss varies. I have seen many situations where leadership, supervisors, and even coworkers tended to assume what would be helpful and supportive for somebody, and it really missed the mark. For example, I've talked with many folks who either were a supervisor or had a supervisor who, when a client passed away, just cleaned out that clinician's schedule, canceled all of their appointments and sent them home for the day. Not necessarily understanding that that could inadvertently reinforce this idea that that clinician shouldn't be doing this work, or maybe isn't capable, or maybe isn't even trusted to see clients while they're dealing with this. So just keeping in mind that folks respond differently, and it's good to ask what may be helpful before jumping in to being helpful. So for supervisors, again, it's not just being mindful of the information I've presented today, it's also being mindful of notifications and what's going to happen next, right? So making sure that you know what those procedures are so that you can support and walk your mental health clinician through those. And also knowing that hearing from you directly is really the best way to notify, clinicians and other folks who are affected whenever possible. This is something that should be getting talked about. It should be integrated regularly into your supervision, whether it's clinical or administrative. You should be asking folks what would be helpful. And again, not making decisions about them or their caseload or their workload without getting their input. If you have gone through one or some of these experiences like I have, you should also consider sharing your own experiences and what that was like for you so that there's less isolation and feeling that they're kind of all on their own with this. So for organizations and leadership, what I hope you will consider doing is really think about the culture of your organization and what it may need as a community, right? As something that's living and breathing and dealing with these situations, is to take a look, and I know this isn't the fun stuff, right? But it's taking a look at your policies and really making sure that they're written to be supportive and not punitive of staff after a client passes. Making sure that you have good notification processes that, whenever possible, it's supervisors who have that relationship to make that notification. Make sure it's very clear, what your process is to debrief individuals who've been involved with the treatment, which should be separate from providing support to those staff as well. Make sure that it's very clear who should be a contact at the organization for legal questions, family, and media. Sometimes this is the clinician and other times it's not. And sometimes it's a variety of folks, depending on the situation. And making sure that you have a very clear, consistent, and easy to understand internal review process. And also for when you have to navigate an external review process, depending on the death. One of the things to really strongly consider is allowing supervisors to be present for additional support to those individuals who are having interviews done or case reviews conducted in connection to the client death. That doesn't mean that the supervisor answers any questions for them, but they're there really as a visible and physical presence of support, and can also go through that with them and help them, kind of debrief and decompress later. So the main takeaways I hope, that you'll think about for today is, again, that every client death can and most likely will trigger some kind of loss response. And that's completely normal, right? It doesn't mean anybody's, less of a clinician or less able to do their work just because they're grieving the loss of somebody that they had a relationship with. And keep in mind that this is beyond your mental health clinicians. Your front desk staff typically also has relationships with folks and other staff around the agency that They just have different interactions with your clients. So when you're thinking about support resources and those supportive connections, make sure you're thinking again of the whole organization, right, as your community. Those different types of death can add layers of context, circumstances, potential follow-up, clinical implications, sometimes potential legal involvement or criminal justice process involvement, family involvement, media involvement. So there can be a lot of layers, and there may be other needs that come from this. The response to loss varies. And one thing we didn't really talk about is it can change over time, right? You're not in shock the whole time you're grieving. You're in shock, and then sometimes you're angry, and then you're sad, and then you're shocked again, right? Or you're angry for a really, really long time, and then suddenly you're sad. So this can change over time. And that's something that should be considered when you're thinking about how to support someone who's going through this. And again, as I've said, doesn't make anyone less competent, less skilled, or less able to work in this field, although they will question that, and some will perceive that others are thinking that of them, that they shouldn't be there. You have to take care of yourself first in order to support others. And that organizational and supervisory response and support is very key to helping make sure that our clinicians and mental health providers are able to continue to do their work well, stay in the field and stay with us. We are seeing that, this is one of those things that can become a workforce issue if you do not have appropriate response policies and support for your staff. So I want to thank you again for coming to listen to our topic today. There are about 4 more slides in this presentation that all have additional reading with links. So, please take a look at that and feel free to reach out to me with any questions.